Thanks for the opportunity. So I would like to present a case in which OCT helped us in deciding the management. So I'm Dr. Senthil, working in Apollo Main Hospital, Chennai. So my patient is a 57-year-old male, executive by profession. He came with the complaints of right-sided chest pain, chest discomfort radiating to the neck and jaw 2 hours back. He did not have any persisting chest pain at the time of his admission. So he complained that he had associated perspiration. He had no other comorbidities earlier. ECG on admission did not show any significant changes. Serial ECGs were taken every 2 hours, also didn't show any changes. So we performed a transthoracic echo, which showed that the patient had normal chamber dimensions and the EF was normal. The patient had a bicuspid aortic wall with a raphe, single raphe, and with a moderate aortic regurgitations. Considering the patient, the bicuspid aortic wall and chest pain, so we thought of proceeding to a CT. So the blood investigation showed that he had dyslipidemia, and routine investigations were normal. Troponin and admission was negative. The CT iotogram showed a morphologically tricuspid aortic wall with fusion, thickening, and calcification. There was no evidence of pulmonary embolism and no evidence of acute aortic syndrome. But the CT coronary angiogram showed that the calcium score was 64. The left main was normal, but the LAD, there was a thick soft plaque in the proximal LAD, causing a tubular 60% stenosis with positive remodeling, irregularity, luminal irregularity, and a napkin ring sign, and a spotty calcification. And it was reported as a vulnerable plague. And the patient again had a chest pain in hospital, and the repeat troponin was positive. So the patient was taken for a coronary angiogram. So the coronary angiogram showed a single vessel disease with 50% stenosis in the proximal LAD with a haziness in proximal LAD, and RC and LCX was normal. So the diagonal was a small caliber vessel with a ostial stenosis. So with a borderline stenosis and a haziness in the proximal LAD, we decided to proceed with the OCT. So this was the OCT pullback. So the distally there was a normal trilaminar appearance. There was some few luminal irregularities, and there was a fibrotic plaque with some areas of calcification and white luminal thrombus. So when we measured the MLA, it was around 2.39 millimeter square, and so these are the measurements. The minimal lumen area was about 2.39 millimeter square, and the minimal luminal diameter was 1.73 millimeter square. The mean reference lumen area was 5.15 millimeter square. So the percent area stenosis was about 53.5%. So these are the various still images. So you can see the plaque erosion. There was the clearance of the was not very good, but still you can note the erosions, and the calcium has been marked, and then the white thrombus is seen. There is a fibrous plaque and the white thrombus images. So with the with a mean luminal area of 2.39 millimeter square and a percentage area of 53% stenosis, so we thought to defer the stent. So a patient with a suspected acute coronary syndrome with a clinical presentation of typical symptoms which are typical or atypical with biomarkers, ECG changes, or risk factors, the general approach should be to perform an angiography. If the angiography is of showing a normal coronaries, we can proceed with echocardiography or MRI to find further diagnosis. If it is of obstructive CAD and there's a clear culprit vessel lesion, the lesion should be proceeded for PCI. And if the angiography shows some ambiguous lesions with multivessel disease, or where the culprit lesion is not clear, or if there is a hazy lesion or calcification, or there is a tortuosity or eccentricity, the patient should be proceeded for intracoronary imaging. So if the intracoronary imaging shows a culprit plaque rupture, the patient can be proceeded for PCI. And if there is a plaque erosion, and if the patient can be proceeded for a PCI if the mean luminal area is very low, or if the flow is not adequate. And if the flow is good and the mean luminal area is good, then patient can be proceeded for a conservative management. So, so in this patient, we deferred stenting. The patient was kept for conservative management with high-dose statins and DAPT. The patient is on regular follow-up. He is asymptomatic currently. So my take-home message is, an intermediate coronary lesion of 50 to 70% area stenosis poses difficult decision-making in PCI. Intravascular imaging has a better assessment of percentage area stenosis, MLA, MLD, which helps in precise decision-making to decide on PCI. Ability to differentiate between a plaque rupture and erosion helps in guiding treatment strategies by deferral of stenting in non-critical stenosis with plaque erosion. The diagnosis of plaque erosion and OCT mainly depends on exclusion of a fibrous cap rupture. So changes observed in OCT in plaque erosion can be the presence of white thrombus with the intact fibrous cap or with the no thrombus and with luminal irregularities. So white cap thrombus with the intact fibrous cap can be a definite plaque erosion, and no thrombus in the presence of irregular lumen surface can be a probable plaque erosion, and thrombus attenuating the underlying plaque in absence of lipidic plaque or calcification immediately proximal or distal to the site of thrombus. So in a meta-analysis of about more than 2,500 patients, confirmed that diagnostic accuracy of OCT-derived MLA cutoff of 1.96 millimeter square for identifying hemodynamically significant lesions in non-LMC lesions. Thank you. Thank you for the opportunity.
Thank you.